Good morning, everyone. Thank you for joining us at this week's seminar. For those online, there's a few people from outside the organisation online. Thanks for joining us. My name's James Ward. I'm the director of the UQ Poche Centre here. Thanks for joining us this morning. Before I begin, I'd like to acknowledge the Yagara and Turrbal people whose land that we have the privilege of sitting, living, working on every day here in Meanjin, and acknowledge their custodianship of country and waterways for many thousands of years. I'm sure Robbie and Andy and Chantel, if you're online, Chantel, will acknowledge country where you're working this morning. So this morning we're going to hear from the Impact STI team. Impact is a study that's been running for the last 3 years up in Cairns, in Gimoy, Ganji country, and it's really about trying to make a difference with STIs in the region. But Sandy and Robbie will talk through that. Chantel, are you online? Can you see Chantel online? If you could show face.
I don't know if she's on.
Okay, yeah. So Chantel has just joined the team, and Chantel comes to us from Mamu Health Service, which is Guinness Farm, and has joined the team with Robbie and Sandy. So thanks for joining us, and we'll have time at the end for questions. So I'll hand it over to you, Robbie and Sandy.
No worries. All right, so yeah, before we start, we also want to acknowledge the land which we're based on, which is the Gimoy Wallabari Indingi mob, and pay our respects also to the neighbouring tribal groups up here that our study works on and with, and also acknowledge old people and elders, past and present. So yeah, as James mentioned, this is our team. My name's Robbie Palm, and I'm the Community Engagement Officer for the Impact Study, and I've been a part of this team since July 23. Sandy, if you want to introduce yourself.
Sandy?
Keep phrasing that.
Sandy, you're frozen. If you can hear us.
Yeah, sorry, I don't know what happened there. So sorry. So I'm Sandy Mitchell. I don't know where Robbie, for some reason went off. I'm the Senior Research Officer up in Cairns, and today I'm sure Robbie's introduced himself, and Chantel, if she's online.
Yeah. All right, so you've probably seen the deadly artwork that we have there. So before we get into it, I just want to acknowledge Taya Hunter, who's the artist for our impact artwork. How this come together, the community advisory group that we work with really highlighted that community logos and artwork really identify who's who within the community. So they really wanted a piece of art for the study moving forward. So on our first community advisory meeting, we established this artwork. And yeah, I think that the key highlights for this is that the group really wanted to highlight the different landscapes and with the Cairns and hinterland region. So, going from rainforest, reef and mangroves. And also, they really found the genomic sequencing really interesting and really wanted to highlight the DNA strain within the artwork, which I thought was pretty deadly as well. But yeah, that's our artwork. And I guess for what we'll talk about today and what we'll cover is a bit of information on the impact study, what's been achieved over the last few years, particularly since 23, community engagement, and some of the ideas for action. So the ideas and interventions that our community have put forward for our study. Forward. Andy?
Have you moved the slide forward? It's not showing on mine and the slide moving forward.
Can you guys see that one at all?
No, I can
Yeah,
just see the
we're-
artwork still.
We're on STIs are complex. We can see it here, but not for you, Sam.
Okay, I can't. Sorry.
I'll do that one.
Huh?
How do I share?
Yeah, I think it might be Sandy's connection, maybe slow.
I'll just
Okay.
try and. Can you see it now?
And I'm just pulling it up on mine. So yeah, I don't know what's going on with my computer, with my no, I'm gonna log out and log back in and see what's going on.
Maybe Robbie, you continue.
Yeah, I'm happy to go through it. So I guess with this slide, Sandy was going through with rationale for our study. So as we know, the STIs are complex, and there's social, cultural, and economic structural factors that impact STIs. And most often interventions are biomedical in approach. And despite many years of effort, we still face significant inequity in STI notifications amongst Aboriginal and Torres Strait Islander people. So why did we embark on the Impact STI research journey?
So I'm back on. Do you want me to?
Are you back?
Yeah.
You can
So
see?
this was So this was an ideas grant that James was successful in getting, and our NHMRC, and started in 2020 to 24. But with COVID in the middle of that, we were able to extend this study till the 2025. So it's been lucky that we've got that extension. So why we've started on this, or why James put in the grant, was to look at if we can have an impact on STIs and reduce the burden of STIs at a regional level. And in the past, as Robbie was saying, most of the interventions have been single level, and what this research project is looking at, developing multi-leveled interventions to see if we can have an impact on that and showing a difference. The unique thing about this research is the real community involvement. So the Community Coalition, as Robbie will speak about later, is how the importance of them being involved in all aspects of the study, and that the community really having a say on the interventions and how this research is being rolled out. And yeah, the single interventions that have failed in the past, looking at how we can reduce the burden of STIs in Aboriginal communities.
See that one, Sandy?
So yeah, so the impact, this study that James put forward, is using a precision public health approach to help design communities interventions and evaluate them to reduce the burden of diseases related to STIs. So you'll hear us say about interventions, but Robbie will explain later that when we're talking about it later, we're talking about ideas for action. So instead of interventions, it's ideas for actions. So this study has lots of data sources that we've been collecting over the years and bringing together and mapping it to see where the hotspots are in the different regions, and where we can focus our efforts. The ultimate outcome for this study is to reduce the STIs in far north Queensland region among Aboriginal and Torres Strait Islander people.
Yep, so our study is located in the Cairns and Hinterland region, which is the yellow there. Within our region, we have 5 Aboriginal health services involved and 2 GP services based in Cairns. Within our health service, we have around, I think, 7 individual sites. So we work with the Poona Pima Cape York Health Council, which is a clinic based in Mosman up in the gorge there. Mullingu, which has clinics in Mareeba, Atherton and Coranda. Wuchopran Health Service, which is based in Cairns. They have 2 clinics, one in Cairns in the central area and also in Edmonton, which is on the south side. Girini Yalamucka Aboriginal Health Service, which is based over in Yarrabah, and Mamu Health Service, which also has multiple sites in Tully, Ravenshoe, Innisfail and Babinda. So with the sites that we have there as well, our Cairns and Hinterland region is our is our impact sites. So this is where we're developing all our ideas for action interventions and hope to implement our ideas. And the Northwest, Townsville and Torres and Cape are our controlled sites. So we're capturing data from there as well and hoping to implement the effect of our interventions and see if there's any changes being made within those regions as well in the controlled sites.
So as over the last 4 years, this study was set out into different phases, so 5 different phases. The first phase was establishing it, so engaging with the health services and establishing the community coalition. So that was done in 2020, and Robbie will talk about it later, but when the initial establishment of the community coalition, we had sort of, I guess we can call them founding members. They've been with us right from the start, and then COVID hit and the community coalition kind of fell apart for various reasons, just not being able to get out to the communities. And but then they've stuck with us, which has been good. Phase 2 has been the data collection, so making sure all our ethics are in place, and then getting health service data, which we'll talk about later, the notification data, the social determinants health, the genomics, and the hospital adverse events data. The other thing that's delayed it, as much as we can say COVID delayed it in Queensland, as people probably all know, the different delays causing with ethics, the PHAs and SSAs has all sort of delayed the whole process. And then phase 3, looking at pulling all that data together and mapping it out and presenting that data to the community coalition and different health services that will inform the ideas for action. And then phase 4 is where we're at now, is we've got these ideas for actions and now looking at implementing them into the different areas, and then evaluating that throughout the process.
So I guess, to highlight now stage 4 and 5 with the new funding that we've received from MRFF funding. So that will be focused on the delivery of the interventions and evaluation. So this is sort of, moving forward past that ideas grant. This is sort of, with all the work that's been done with those phases that Sandy mentioned, this is the phase that we're leading towards and looking forward to getting into.
Yeah, and I guess as Robbie briefly mentioned, James was successful late last year in securing an MRFF grant for another 5 years. So that we're not going to talk much about that grant. That'll be a presentation, I'm sure, in the future months. But yeah, so right now the focus, what that grant has allowed us to do, is actually really spend time in developing these ideas for action and really being able to do some good evaluation and hopefully see some good impact with these interventions. And so, as we spoke earlier about in the past, interventions and ideas for actions have been single layered. So what is unique about this is that the ideas for actions that we're implementing is going to be like a suite of interventions, and it's going to be a multi-layered approach. So we're going to look at individual level interventions, community levels, health service interventions, and cultural, social, and structural interventions, and combining those in a suite of interventions that we can present to the community and health services. And Robbie will go into that further later in the presentation.
Just trying to move forward. So yes, I guess what we've done so far, we've had the relevant ethics approval for the ideas grant. We have an active community advisory group that was established in 23. Strong engagement with our health services and communities. We've had Granite installed for health service data. Sandy's also going to do a bit of a presentation on the data collection and how that's worked. But yeah, we've also had the PHA notification data, genomic sequencing, the determinants of health data as well, and some of the mapping. So I'll let Sandy get into the data collection.
Okay, thanks. So as Robbie said, and as we've sort of briefly touched on the data, we've got lots of different sources of data that we're collecting throughout this project. And so we've got the health service data. And if you were I listened to Carol's presentation on the Atlas data a few weeks ago, you would have heard about the data that Atlas collects. And so our data that we're collecting is similar to the Atlas. It's for our project. So we've got, we collect the STI data and the management for our health services. So we have a software, Granite, installed in the different health services and are able to provide them with 6 monthly reports. We've also got genomics for gonorrhea and syphilis. So we look at the STI transmission routes and any resistance. We're collecting the social determinants of health data. So income, employment, housing, education, alcohol, infrastructure, transport, and access to healthcare, and seeing how that impacts on health services and health service delivery and STIs. And then we're also collecting the notification data for the area and any STI related hospital visits. So this is sort of a brief summary of the different data that we've collected. So we've got the Granite installed in all our AMSs and our Aboriginal Medical Services and our 2 GP sites. We've got the genomics coming in from gonorrhea and syphilis from the private labs. We've got local data, and we've got the STI notification data. Cairns Sexual Health is sort of highlighted there because we've got an ongoing issue trying to get the Queensland Health to agree to get Granite installed in their computer so that we can get their data. And so we're still looking at different avenues and different negotiations on trying to gather that data so that we can have the full picture. So as I mentioned, the genomics, the sequencing of gonorrhea and syphilis, isolates and DNA to improve the understanding of sexual networks. As we know, people travel up and around far north Queensland. So looking at how if someone's tested in Cairns and they're testing positive for gonorrhea there, and someone's testing positive in Cape York, we can see if there's a match with the DNA, and seeing how the travel routes, and then also identification of drug resistant strains. So this was interesting. When we had our recent meeting, people were asking about if we had the international data with the different strains. And as you can see, this is preliminary data from our genomics, and we've still got hundreds of samples still to analyze. But this is just preliminary and showing that that some of the strains that are coming in central Queensland and far north Queensland, like the 11706, is common in Sweden. So we're looking so we can identify that international link as well. And then also the resistant strains that are popping up in central Queensland and far north Queensland. So socially determinants of health, the data, as I mentioned earlier, we're collecting is the income, housing, education, employment, and alcohol licenses, and the alcohol restricted areas, and also access to healthcare. So from that, the next slide, from that, we haven't really found anything too surprising. This is just sort of some of the risks to health, the stuff that we already know: low income, poor housing, limited education, lack of access to healthcare, all have impacts, all have our risk to health outcomes. And this is just sort of our social economic outcomes index for our different sites. So the health service data, this is similar to what Carol presented. So these a few weeks ago. So this is the sites that we have. As Robbie mentioned, we have 5 AMSs, but we have 9 sites, and then 2 GP offices that we collect data from. So this is just to show this was a study that James was involved in, and showing for mathematical modeling for syphilis, and to have really any impact on reducing the rates, you need to have a coverage of up to 60% for testing. And it's interesting when we're showing the reports to our health services, that's often what they ask. How are we in the grand scheme of things? Are we making an impact? And some of our sites have, if we're looking at our lowest site, it has like 9% testing coverage, and the highest is up to 40. So they're nowhere near reaching the 60%. Well, they're nowhere near reaching the 60% coverage yet. So it highlights the need to look at using that as a way to develop our interventions to increase the coverage of testing. So this is just showing broad from our sites, the testing, diagnosis, and treatment, how it reduces male and female, and that the amount of people that were tested and diagnosed and treated. This is same day treatment, so not often people are getting treated on the same day, and as you can see, it's 0, but it just shows how it reduces it. And so if we go on to the next slide, we'll see that the highlights that females are getting in and getting tested more often in the blue bar rather than the orange bar, which is the males. And so just looking at that's another highlight for where we need to focus our energy on developing ideas for actions to increase the testing for males and getting those males in and getting tested.
I also want to highlight too, with our health service study, with the data we get from Atlas, we've spent a bit of time meeting with our health services as well, and presenting that data and getting feedback. And I think there's also been great conversations within those meetings. I think when we give the data and having those yarns and looking at these charts, we're able to have those discussions as to and use their knowledge, because they work within the clinic and really look at why are some why are females attending higher in certain ways, or why is the retesting higher or lower. And it's really interesting to have those conversations about the data, and not just present it. So and also with our community advisors, we've also presented de-identified charts as well, and had some great conversations and getting the community members' perspective on the data as well. But just thought I'd highlight the different ways we've used that data.
And I think just adding to what Robbie said, it's been really interesting presenting the data, because when you present it and looking at sort of when the numbers are really low, the health services are able to identify sort of why that is, and are like right away they're saying, oh, looking at solutions, or looking at ways to sort of increase the number of testing, or increase females, or increase, if it's a lag in the time to treatment, then looking at and ways sort of as we're presenting the data. So it's been really a good way for them to come up with ideas on how to improve their services as well. And then on from this, as I said previously, we've been doing some mapping. So this is the notification data. So looking at where the hotspots are in the Cairns and Hinterland region, and where we need to focus our energy on where the higher STI rates are. And I mean, if you look at it, it's Cairns is kind of Cairns City. Well, that's kind of a given, because it's got the higher density of population in that, and you've got the services and sort of the engagement there. And then the next slide shows on a regional level. So even though I don't have a pointer to point, but that area that Robbie was showing earlier is our impact sites, which is Cairns and Hinterland. The point where all those dark red areas are, which the higher rates are, that's Cape York. So, and that's one of our control sites. So what our hope is if we put some interventions and develop some ideas that are successful in the Cairns and hinterland, we'll start to see a reduction of those numbers up in the Cape as well as we're collecting that data. As we know, people in the Cape from different communities come down to Cairns, have a fun weekend, and then go back to their communities. And so, in summary, why are we gathering this data? It's sort of highlighting what we've done from the mapping and bringing it all together. So we're being able to identify hotspots, and we're able to sort of pull out where the gaps are and where the work needs to be done. And from this, it'll give us a better understanding on how we can make an impact on reducing the burden of STIs. And I think that this is a good sort of time to ask if there's any questions from the group about that. And if there isn't, then we'll roll on to Robbie and the community engagement. No, okay.
All good. So yeah, I'll have a quick yarn around the community engagement. So with the community engagement, for me, it's hard to put it in a nutshell. So really what I want to focus on is relationship building and the effort that takes to, build relationships and maintain, and also about our community's involvement in the study. So really focus on the community's involvement with the impact study in the last couple of years, particularly with our community advisory group, and also the co-design process. So the workshops and some of the co-design work we've done with our communities. So relationship building, with this one, what I really wanted to highlight that, coming into the communities that we work with up this way, they are in far north Queensland, but our communities are very different. So we really need to take that time to, build our relationships with mob and create those genuine connections. And yeah, some of these photos we have here are some of the, examples of what we've done. So down the bottom left I was invited to the Yarrabah Men's Health Forum by Uncle Darren Miller there. I spent a lot of time with the men's group and got to the point where I was invited to speak to the men about the impact project and sort of have a yarn around how sexual health links into, men's health as well. Top left was one of the golf days up in Innisfail. So Mariah Liza, who just left us last week, done a lot of work with us with the impact study, especially within community engagement. So they done a golf day up that way in Innisfail, and the Poche Centre supported that, and they had the Young Deadly Free emblem on those. And yeah, that was just a new way of promoting sexual health in the area. And the health services that we engage with, seeing that, and now a few of those want to, run their own golf days. Top right is YPC, a Yarrabah health check for young people. Sandy and I spent the day, meeting with community members and working alongside the health service mob at the juice stall. I'm talking about Boost Juice, but we're making juice there with the mob there, and people are doing their orders in. Yeah, and I really like that. And the bottom right is just a Innisfail NAIDOC Day doing some surveys around sexual health. But overall, really what I wanted to highlight there is that, especially with the research project, we have to take time to, establish the relationships, but we also have to maintain those relationships as well ongoing. And that takes a lot of time and effort, and is important. So now I'll yarn a little bit about the community's involvement in the study, and I just have a timeline there. I'm not too sure if you guys can see that, because I know it's a bit small, but can you see my cursor there?
That's all good, yeah.
Yeah. So I guess, as Sandy mentioned, with the interruption from COVID, starting in July 23, with our community advisory, it was starting from scratch. So we spent a 5-month period between July and October, really, like I said, creating those relationships in community, introducing ourselves as foreign visitors to the community, and introducing our project and, what our aim is and why we're here. And, following that engagement, we're able to do some recruitment for our community advisory group. And with this group, they really are the heartbeat of our study, and been able to lead us in the right direction and help us navigate, with our project, on both sides of our study. So, we've hosted around 7 meetings with our community advisory group. And within our group, I think one thing to highlight is that we have diverse, experience. So we've had participation from Morgan Dempsey from the Cairns Sexual Health up here in Cairns, and he's pretty well known around this way. The Taya Hunter, who's an ex-nurse. She's not practicing anymore, but she's based up in Kuranda way. The Jabberguy Rangers, which are based up in Kuranda as well, which I thought was pretty deadly having them involved. So I think, when we were doing the recruitment, we really wanted to, look at community members as everyone in the community, not just, mob that are working for health services or working, so everyone. And also we had Brother Errol Choiki, who's, shout out to him. He's been a part of the study for a long time from Yarrabah. So as I said, we had seven meetings all up, and the meetings we're planning to do those ongoing. But a lot of those meetings were focused on, as I said, presenting data, working with our community advisors to really understand, what's happening in community in regards to sexual health, in regards to interventions, what might work in their community, what's happened in the past, and what can we learn from those. And so following those 7 meetings, we're able to come up with a set of lists of ideas for actions that our community advisory group have come up with. So we had a big list of ideas from our group. And we got to the point on the 4th of June where we were able to host a gathering of community knowledge, which I'll speak further in detail after this. But that was more or less all the work we've done with our, community advisors and our health services, putting that all together and presenting that to a wider group within the community, some who've engaged with the study from a distance and some not at all. But yeah, to have a wider group from the community to workshop those ideas that have come up with. So following that, we've recently had a meeting on the 12th of March to really focus on our health services and getting them further involved in the study and having the health service lens and trying to get them to workshop health service interventions as well. So as you can see with our community advisors, I think what's unique with us, they've been involved within our study, not only just for the meetings, but through our workshops and also individual meetings. Say if I go to Yarrabah, I'm checking in with Errol from Yarrabah. If I go Kuranda, I'll pop into the Rangers and I'll see Taya and have yarns with them as well. So their involvement's been pretty strong, yeah. So speaking on co-design, I sort of touched on it, but yeah, we met with Sue Muller from the Better Together Collective to sort of develop a framework for our co-design process. And really, it's pretty simple. It's looking at setting up for success. So within that was building those solid foundations, collecting the data, sense check. I think one thing also to highlight is when we were developing the ideas with our communities and health services, the sense check process was important. We're really talking about the scope of our research project, talking about sustainability around ideas for action. We can't build $1 million building and stuff like that. So really looking at, ideas that meet community needs, but are also sustainable moving forward. So once we got the group of ideas for action, I think I forgot to mention that. So the ideas for action is what our community advisors call for interventions. So when we were using the term interventions, the Timmy from up Kuranda way there, he's a ranger. He didn't like me using it, and I have a bad habit of using it, as you can see. But they come up with the term ideas for action. So now you know what that means. So we come up with the ideas for actions, and we had to get to the stage where we had to workshop that with community. So we've done the community workshops, and within the workshops, we really focused on grabbing those ideas for action and presenting them in multi-layers. So really looking at the ideas that the community come up with, and looking at, you know, the different layers within the community and which they impact. So the groups, you know, looked within the individual level, so ideas that impact individuals, community levels, so the community, clinical, so within the health service, and social structural, so some of those ideas that impact the structural area of the communities. And then working out, you know, like a combination of those ideas for action and what that looks like within the community. So following the workshop, the sense check is ongoing. So we continue to work with our communities and develop these ideas, and then hopefully get into the stage where we can implement. So as I said, we held a gathering of community knowledge. So this was a pretty deadly event that we held. You know, we had diverse experience within the room, and we had workshops that really shortlisted the ideas and put them into those layers, and also continue that sense check. So to yarn with the wider group around, you know, sustainability and using their experience in the group, you know, what that looks like in their community. So this was held at the Jabbergai Cultural Centre, which is closed now. So this might be the last workshop that was held there. But yeah, it was a great space. Uncle Ernest gave us a nice welcome, and yeah, it was a really deadly day. So as we keep mentioning the community ideas for action, now I'll go into a little bit of detail as to, you know, some of the ideas that have come up, and how they were sense checked as well. So this checklist here was generated by our advisory group. And when I spoke earlier about sustainability, these are sort of some of the things that the community came up with. So I'll just go through a few of these. So just, yeah, obviously, do the ideas meet community needs? That's very important. I think what was very interesting is the, you know, collaboration between Queensland Health and the AMS. I think the community really highlighted that, you know, that could be a, you know, that is a barrier, and we need to work on that. Are the ideas for action achievable? Time frames, I think that's very important, and it was great that our community was thinking about that. And also, yeah, things like budget and who needs to be involved. So, yeah, this is our shortlisted list that we've come up with. I'll let you guys have a look at that. But after this, I'll go into detail for some of the ideas that have been really stand out within our group, and sort of explain the aim of those ideas and the background as to how they've come up. But as you can see here, this is the layers that they sit in, which I mentioned earlier. And I'll get into some of the other ones. I think another thing to highlight as well is that our community and those workshops have done a lot of work around, you know, the community, cultural, social, structural, and individual levels. And the meeting that we held previously, and the work that we want to do in the next 6 months, is work really closely with our health services to build ideas and really get some, you know, clinical expertise on, you know, ideas for action for the study. So to look within the cultural, social, structural level, condom access. So yeah, obviously to increase the access within our communities for condoms. So the background around this was, you know, there's, in some of our communities, there's a limited supply, and they also mentioned, you know, sometimes, you know, the health services are the only place where there is access. So when the health services closed on the weekends and only open Monday to Friday, where are the other locations where the condoms can be supplied? And also the shame and stigma around going to the local stores and buying them. So that's one idea. Targeted clinics. So this was more focused on, you know, the individual groups within the community. The advisors really highlighted that, having our individual activities and particularly clinics for individual groups in community have really worked in the past. So looking through our study, if we focus on the different groups within our communities. So within the community level, we're looking at roadside messaging. So this was to co-design roadside signage that promotes sexual health and displays signs in preferred community locations. Where this really came from is that some of our communities up here have roads that lead one way in and one way out. The community really highlighted that, sometimes health promotion in general can only be, found within the health service. So looking at other ways, that our study and the health services can promote, have health promotion within the community. So having them on the road, I think an idea that the community come up with, is having at the bottom, the Yarrabah range, having a trivia around, health or access to a clinic, sexual health, and having trivia, when you're getting into the community. So having signs along the way. Also mentioned around the Cairns area with the local buses. So some of the promotion within, within the buses around, and yeah, it's just really highlighting that there's a lack of promotion in the community in general, and that there's need for more attention in other areas of the community.
So also one of the suggestions was regional social media campaigns. So doing a competition like similar to what happened over COVID, where people send in their TikTok videos that are promoting different aspects of sexual health, and then have competition within the services. And so really highlighting the need to expand the use of TikTok, Facebook, and Instagram to get to our target population, which I don't think we've mentioned, is between 15 and 24.
So health promotion, so to provide cultural, safe and localized health promotion, the group really highlighted that there's, up this way, there's not much access to material, and a lot of the material that they have access is outdated and a lot of the times from other states and territories. So the group and the health services talked about developing stuff that's, made and is more understandable for the mob up this way. Sexual health network. So this was a big push, particularly through our health service members within the advisory group, and they really just highlighted the fact that our health service mob, they don't really have the opportunity to network, although the area that we work in is very small. They find that sometimes, it's only at big community events or conferences that they take that time to network. So we held a meeting late last year to do a bit of planning around what a sexual health network might look like. And we had some great yarns there around sustainability again, as there's been previous networks and learning from those. But this is another idea that the community's come up with. And I think the meeting we had 12th of March really showed the great outcomes from networking, and I'll speak later on about that meeting. So to move forward on the individual level, so these are ideas that impact individuals. So a popular thing was the text message nudge. So similar to the social media stuff, I think what they're talking about, how accessible phones are to people these days within our community, how much they're used. So the aim was to develop nudges and texts that can be sent out from the health services to community, and just prompting different messages around, sexual health education, going to the health service, and those messages will be developed with the community. But it's just around having text message nudges through our study that will be delivered to the community.
And I think I'll just jump in here. I think one thing that was really important that they wanted to stress here was that it would be good if it came at a regional level, so it wasn't just at a health service level, so people weren't being seen as being targeted like from the health service that they needed to come in for their sexual health checkup. But if everybody was getting it at a regional level, then it wouldn't be as shameful.
So yeah, another one with the individual, really quickly. This is, one that was brought up through our advisory group, and I think it's pretty simple, similar to the Giraffes card. You get a free coffee, but this one's just more around, getting young people in. The Yarrabah do a good example of this through their YPC on their health passport, and it's you get your sexual health screen, pathology, vaccination, and at the end, you get a voucher or whatever the incentive, which is developed through the health service. But this is just another way of promoting, getting people to the health service, and also people feeling accomplished about getting health checks and all the other stuff done as well. So moving forward, the health service level, as I said, there's not much. Sorry.
Oh, no, go ahead.
This is
yeah. Sorry. So I guess the highlight, there was workforce training. So we've got all these great ideas for how to get the community into the health service, but then once they're into the health service, what work needs to be done in the health service to get them ready for people coming in to get testing. And it's interesting, the information that we've gathered is from the community. So one of the things that they really stressed was the need for confidentiality and in small communities. And when we had our recent health service meeting, the response was, well, we're all health professionals. We all sign a confidentiality agreement. We all know about confidentiality. It's kind of like a myth that we're going to spread the rumors. And stepping back and saying, actually, no, this is what the community wants, because the community wants to be reminded that when they are going into a consult with a health provider, when they talk to a health provider, what they tell them is confidential. And so even though the healthcare provider is aware that they need to, by signing confidential agreements, and that they're aware that they need to keep things confidential, the actual community need that reminding. So they're asking for the healthcare providers to remind them during the consult. So it was just a different slant, like coming at a community level lens.
So yeah, as I said, we held a meeting on the 12th of March. Some of our mob from the centre came up. Yeah, this was another great meeting, but focused on that health service level. We had, people from CEO, health service workers, community members. But really focusing on developing those health service level interventions and working further on our working with those health services. But this was a really good day, and we've done a lot of work, and we still got a lot to do.
So next steps for the project are, and we're, as Robbie has mentioned, refining those ideas for action for the community as well as the health service interventions. We're also in discussion with health behavioral change consultants. So we're looking at working with a behavioral change consultant to develop, help us develop the interventions, and then continuous throughout the whole. Next step is continuous engagement with the community as well as the health services.
So before we finish up, I just want to acknowledge the contribution from our communities and a lot of the time they spent and knowledge they've provided to the study, particularly our community advisory group. Some of them have a really long way to travel to come and support the study, and we really appreciate the contribution they've given, since this project started, and the contribution they'll give moving forward. They really are, as I say, the heartbeat for our study, and we really appreciate their contribution, and also our funding mob, the NHMRC, and the investigators and associated investigators are part of the study as well. But I mean, to wrap it up, I think when we started in 23, we had a lot of work to be done. And the meeting we had recently on the 12th of March, it really was a good opportunity for us to sit back and look at a lot of the work we've, that we've come up with, and we've come a long way, and we sort of look forward to continuing those efforts and seeing what happens in the next 2 to 3 years. But yeah, thank you. So if there's any questions, feel free to throw them in the chat or answer them.
Excellent. Thanks both, Robbie. And it's a lot to get through, 3 years of work in 40 minutes. So thanks very much. Open to questions from anyone on the floor. It's a different methodology. It's multi-level. We're going to evaluate multi-level interventions. Probably raises some questions for people in the room. Any questions?
I'll have a go.
Hi, yeah, Annie Mary, yep.
I was just wondering, I guess thanks, Robert and
Andy, yeah.
Sandy, thank you.
Yeah.
For the presentation. I was looking for the post sign throughout the presentation. I think the background story and the history, the local artwork, great. But I was looking for the post stamp.
Yeah.
Emblem. Is it not? This is out of Poche.
It's definitely out of Poche.
Yeah, it's on the front slide, but
Yeah, it's on a
we have
few of
very
them.
different-
I
Yeah,
think,
there,
yeah.
yeah.
Oh, okay. Perhaps it should be filtered throughout the whole document. I mean, that's just a mark of respect and plus ownership. And which leads on, Polly, thank you, to the next question is, with all the work that UMOB have put into it, is the skeleton, the framework of what you've done, translatable to any other piece of research that comes out of Poche?
Yeah, I think to answer that, I think James just touched on it before, but I think really focusing on our community engagement, and I think the methodology for our study and how that's been done. I think what's really unique is, we work for the Indigenous research unit within the uni. We have James as, Blackfella director, and mob working in the community with our communities. I think it's one thing to learn from this is what we can, the outcomes that we can achieve when we have mob on all levels of the project. So I think that's one thing. I think there's many things, I think there's a lot to think about, but really on the top of my head is just, obviously working with our communities and having representation from our communities and mobs with issues that impact our mob. I think that's been real successful up this way.
And so
Yeah,
you
and
would agree. Sorry.
Sorry, I was just gonna sort of just highlight that and sort of reinforce what Robbie has said, that the framework with the community engagement that he's done is going to be evaluated in the next kind of steps as well, and definitely the importance of that community involvement throughout will be transferable to other research projects.
Thank you.
An important part of it.
So good idea, James. What do the rest of you think? Good idea. Yeah, and I think if look, sexual health will be, it's one of those topics that, back in the 70s and further on where there would be sporadic, hotspots throughout the state of Queensland. Queensland government would throw money at that particular area, and that would last maybe, for a minimal amount of time until the next. So I'm not sure if that's the right language, but it's one of those things that the more research, the more ownership by community, I believe, in terms of addressing a lifelong, situation or condition, within our communities and family and mob, there's key is the information. I believe the key is information and ownership, and definitely all those things that you mentioned, about the relationship building is definitely key. So with that, I'll stop at that. But those very communities that have been mentioned in the resource, remember me sharing with that, this wouldn't be all of you, but some of you, maybe just reflect on the circle of health, the definition of health, and the Far North Queensland research. They're the same communities. So what they're saying, what they were saying back in the 90s is being reflected here, this century. You know what I'm saying? So I think our communities, the resilience and the backbone or the blackbone within our communities doesn't change. But it is working with people, researchers, UMOB, to be able to assist communities to take ownership and lead for the next generation. And I think STI is a generational situation, unfortunately. But that's my opinion. Thanks.
Okay.
Thanks, you.
Question online.
Yeah, I've just seen that question online there. Oh, sorry.
Yeah. What's the question online?
So probably just wondering, would sending text messages about STIs community members increase chances of domestic violence? So to answer that, I think with the actual nudge that we're presenting is not really based around results and stuff like that. It's more around just nudges around education and prompts to attend the health service. But we definitely work with our communities and health service to develop the messages that are safe for our communities. Also, thanks Kenny and Carla for your words. Appreciate it.
Yeah, I was just going to say, just to highlight that as well, that was mentioned about the potential of people are getting messages, and that's one of the reasons why they really wanted the text messaging to have a regional approach, so it wasn't just singling one person on getting it, that everyone was getting it. So it was in a way to hopefully not cause DV if they're getting the text messages or not. Yeah,
sure.
Promote.
One final question.
Thank you. It's a fantastic presentation and also great research topic. Thank you, Robbie and Sandy. I have a question about, based on all the research or engagement you have done for the last 2-3 years, and when you'll be developing the interventions, is this intervention going to be gender specific for males and females? Or is the sense from the ground now? Because I guess STI is very defined for males and females.
I guess I'll just start, and then Robbie can. I'll just say we do have a male and female. We started off with 2 males as community engagement officers, but it really became clear that we needed a male and a female to be able to engage. And some of our communities, it's really they definitely wanted it separate, and then other communities felt that that they could be seen together. So yeah, Robbie, you can.
Yeah, and I think to add on to what Sandy's saying, really what we've come up with are the ideas, right? And when we start to talk about implementation and what that looks like in the community, that's when we can start speaking with the health services as a region and discuss, look really deep into what our approach is going to look like, whether it's targeting 15 to 24-year-olds or females or males. But really what we've come up with at the moment is the sustainable ideas from the community, and the work moving forward now is to really grab those together and look at that implementation plans for our communities and start to think about those things now. Yeah, but there are definitely things that we're thinking about.
So one of the things we know is that 18,000 women came to the clinics in 1 year and only 8,000 young men.
Yeah.
So there'll be universal ideas for action, and there'll be male ideas for action because we need to get more men into the clinics.
And I guess just to highlight some of the data that came out of Atlas was one of the clinics had a male GP, and they had high numbers of men coming, well, higher men coming in than females. And so we were looking, when we were presenting the data to that, we were like, oh, you're unique. Why, sort of, what have you been doing to attract more men? And they had a male GP and a male nurse in that clinic. But since the male GP has left, they've started to see a decline in the men attending the clinic.
There's one more question online.
Yeah, we can't see it, but do you want to?
Come on, Sandy.
I can't see it. What is it?
It's just saying, wondering if you could share some of the insights you might have learned about the big differences between female and male willingness to test, and why do you think the men's testing rates are so low?
Okay. I mean, a lot of our clinics have the women are coming in because they're childbearing age, so they've got they're coming in if they're getting pregnant, looking at getting pregnant, and so they're more engaged with the health service regarding that. So that's one of the highlights. We have some of the clinics are doing things with dads to try and encourage them to come in. So yeah, anything else you highlighted, Robbie, between the two on why we're getting more females than men?
Yeah, just adding to that, I think, yeah, the mums and bubs clinics are obviously one thing that's pushing up the numbers and the data. But, you know, speaking with some of the men within the community, I think they speak things about, you know, I think we had mentioned earlier about the targeted clinics. I think the men, you know, want to look at, you know, having the men's clinics and really having more male representation within the health services. Because I think within some of the health services in the community, the female dominant within, you know, admin, doctors and health workers. So really looking at that as a barrier. And yeah, I think there's many things to it. But yeah, I think those are sort of been the big highlights.
So thanks, everyone. We might wrap it up there. I want to just say thanks very much, Sandy, and Robbie, and also acknowledge Mariah Laza, her contribution, but also welcome Chantel. I'm not sure if Chantel's online. Chantel's joined the team recently. Welcome, Chantel. But I'll tell you a little story about the importance of this centre and what we're doing. Robbie did his interview with us about 2 years ago, and he didn't hardly say boo. You can see how his confidence has grown in research, and that's what we're here for. The end game is to build capability and capacity with our people, and he's got a big future ahead of him. And thanks very much for both of you and Mariah for that, and Robbie. Well done. Yeah.
Just quickly, James, before you.
Thanks, Robbie.
Before you finish, see what you just said there? That should be on the last page of this presentation.
Yeah.
Because that's when you mentioned it, at the beginning of the session, you mentioned about Robbie at the end.
Yeah.
And because you know that, Robbie knows that, everybody in the room know that. Because that's the person.
People have seen him grow.
That's the person. That's the person, see?
Yeah.
Yeah.
Anyway.
Food for thought.
Good.
I just don't like big note in myself.
Yeah, good work, both of you. Thanks very much.
All right.
Thanks, Sandy and Robbie.